All right, let's get started. Good morning, welcome back. So many familiar faces and names. My name is Callie. I work with Promises. I'm on the marketing team here. We're having back Trish Caldwell today. She's our Senior VP of Clinical Operations. If you've taken a training with Trish before, that's probably why you're back. She's a great speaker, and I'm really excited to have her back today. She'll be back at the end of the year as well. So if you're here today and you want to see more of Trish, we'll have her again in a few months. So today we'll be talking about the intersection of well-being and patient care, which is, I think, very pertinent to anyone. And again, if you're here and needing ethics CEs, you're in the right place for that too. So this is accredited through NADAC and NBCC today. You can go to the next slide, Trish. So Promises, I want to introduce us as an organization this morning. We offer both mental health and substance abuse treatment. So we have 9 treatment centers across the country. Excuse me. It's very early where I live. We offer residential, outpatient, PHP, and detox levels of care. So to speak to our mental health programming a bit more, we treat clients with personality disorders, anxiety, trauma. We have trauma-informed certified staff and PTSD. So we also have a very involved family program, and that includes not only very hands-on information during treatment, but as well as weekly online meetings. So those meetings are actually open to anyone. So any of you that have clients that want the family to be more involved, or you think the family should be more involved, we do offer weekly webinars that anyone is welcome to join. If you were with us last month, Gwen Swift, she is one of the leaders of our family program, and she will be speaking. She speaks weekly for those family webinars, and I will drop the link to that after I finish this. So I'd also like to highlight we have an alumni program. So right now across the country, we're offering we have celebrations called homecomings, where anyone that graduated from a Promises facility comes back to the facility, comes back to their home, gets to reconnect with the staff, with other clients, and it's a really beautiful time at Promises, and it's one of my favorite things that we do. So that's going on right now as it is Recovery Month. So lastly, I just want to announce that we are opening a new home for recovery in Dallas very soon. So if you're in Texas, you're in Dallas, you want to learn more about that, I'm happy to share some information. So we're excited about Dallas. Okay, move on. Our CE process. Everyone take a deep breath. We are here and we are in the right place. You have to be here for the full training. If you're already online, you're likely going to be great. So your email has already been collected because when you sign into Zoom, when you are here, it acts as your sign-in sheet. So I already have your email. Everything's good to go. The only thing that I ask is that you're not sharing a device with anyone else. So if you and your colleague are trying to both view this webinar, you need to be on separate devices because, again, that's your sign-in sheet. So you need to be on separate devices. If you move from your computer to your phone, that's totally fine. Just, I will make sure that those things are connected and that you're here for the full amount of time. I go through the data afterwards. I make sure that if you hopped off for 10 minutes or your Wi-Fi went down for a little bit of time, I add up that time and I make sure that you get your credits. So after the training, you'll receive an email from JotForm. You must fill out this survey to receive credit, and that needs to happen before next Friday. So you have 1 week to fill out the evaluation form, and just make sure that you give me an hour or two after this training. Again, I have to go through our data, and then I send out the evals to everyone that was here for the required amount of time, and that email will come to you from JotForm. So keep an eye out for that. I have noticed that if you have like a Yahoo email or Comcast, they don't seem to like my JotForm emails very much. So just know that I will be sending those out. And if you don't receive an eval by the end of the day or an email that says you did not meet the requirements, shoot me an email so we can make sure that we get that to you if it doesn't come through. You will then, after you fill out the eval, it automatically kicks back a certificate. So it's also from JotForm. And again, that's an automatic email. So if it doesn't come to you within 10 minutes of when you fill out the evaluation, let me know because I have them all stored on my end and I can make sure you get your certificate. But that should be a pretty easy kickback. And then we'll have this recording, we'll have slides, we'll have resources, and those will all be out to you Monday or Tuesday next week. Okay. Okay, so during the webinar, just a few housekeeping things. This chat box, this is great if you guys are asking me about CEs or technology, anything like that goes in the chat. That's for me. Anything that you want to ask Trish, I'd like to reserve for the Q&A. So that will be where Trish will look to get the questions about the actual presentation. So I just want to make sure that the chat is reserved for anything else that you need to talk to me about. And again, this is recorded, so if you want to take notes, you're more than welcome to, but you will have access to this after today. All right, a few upcoming trainings. We only have a few months left of the year, which is pretty unbelievable. Next month, we are talking about integrating ASAM, in-person center documentation and treatment planning. So if any of you joined the webinar with Jamise a few months ago, this is a great follow-up to that training. It's really all about the details of treatment planning, and that's led by Rhonda and Megan, Corporate Director of Clinical Services and our Regional Manager of Utilization Review. I'm excited. We've never had two presenters before, so that should be a really engaging way to talk about treatment planning. And they're very excited. So that will be next month on October 25th and then November 22nd. We do these the fourth Friday of every month. Easy way to remember. But November 22nd, Trish will be back talking about measurement-based care and skills to enhance recovery. So that'll be great. Next slide. Oh, Trish, take it away. This is all yours.
Thank you, Callie. I am going to start by apologizing. I had some minor technical difficulties, so I apologize if it looks like I'm not necessarily looking at the screen. I am looking at the screen, but my screen is to my right. So today I am going to be talking, and I know that there was a couple of questions about the ethics that is on me. This is an ethics training, but I'm doing it a little bit differently. So what we're seeing is chapters, right? So we're going to talk about the importance of ethics in our relationships, patients' rights, confidentiality, and preventing harm. But where I'm going to spend a lot of my focus is something that we haven't really talked about, but the ethics of our own well-being. So how do we look at, in light of everything that's been going on, and we're going to talk a little bit about that, right? Post-pandemic, working in a field, a behavioral health field, where we are bearing witness to others' stories, traumas, experiences, lives. How are we measuring our own well-being in a way that impacts our ability to serve? So I'm going to spend a little bit more time on that. So when you're looking at the objectives, and again, normally I don't do the objectives. I don't highlight them because it's everything that I'm going to go over, but just in light of the conversation and some of the confusion that was on my part about the ethics component to this, we are going to explore impaired well-being as a risk for compromised ethical decision-making. And then look at ethical practices related to our own self-care. We'll talk a little bit about the difference between those two. And then what we can do organizationally to be able to support our team's well-being and what the rest of their service. So again, I'm going to take a little bit of spin on what ethics is, because I think that today more than ever, this is an important conversation for us to be able to look at in the way that we are showing up to do the work that we are wanting to do for our patients. So again, I'm going to throw in a couple of little quotes because I think it highlights exactly what it is that we're going to be talking about today. In behavioral health, our commitment to ethics not only guides our actions, but it does shape the future of our profession. So I have been in this field for over 27 years. I have seen a lot of things change, a lot of things evolve, right? We're talking about measure-based care in the next couple of months. There's a lot of movement in behavioral health. But when we look at what the ethical principles are that guide us to do our work, I'm going to go after some of those concrete ethical principles as we start to navigate these conversations. But I do think that it's important for us to recognize that our commitment to ethics, and I'm going to poke at how do we look at ethics a little bit differently, is going to help to shape the future of our profession. This idea of, so how do we support one another? What do we look at when we're understanding burnout or compassion fatigue? What does that even mean for us? This is going to start generating some change in the way, hopefully some change in the way that we continue to support each other in our profession. So what are ethics and behavioral health, right? So again, I'm going to kind of review the purpose of ethical standards, but I do think if this was not on a webinar and I was able to kind of feed back and forth within conversations, but I want you to do it in your head. What are some of the ethics that you think we as practitioners should be guided by in the course of the work that we do? Right. So I want you to put those thoughts into your head, jot them down, or just kind of keep track of them, because I want you to see if they align to kind of the conversation that we're having today. So what are the ethics in behavioral health? Where do we fall in? When we talk about the purpose of ethical standards, right, we know that this is to guide our professional behavior. We're going to talk about that. We are all professionals in the behavioral health space, no matter what it is, and no matter how we're serving. Right? We are all professionals in behavioral health. Otherwise, we probably would not be on this call. When we look at all of our roles that play a crucial role in the experiences of our patients. When we talk about it, standards, is that we set a culture of resilience. Right? So this is where we're going to start playing around with. There's some things that are so concrete that we need to set the standards through very clear expectations. And then when we start to get into this movement of well-being, it's going to be important for us to figure out, so what do we want to set as the culture within our own organization that sets the ethical practices that we follow, right? So when we start to kind of play around with those boundary lines, it can start to make things a little bit blurry. And so again, we'll talk about that in regard to like a confidentiality, but then we're going to talk about it in the way that we experience ourselves as showing up. So we want to be able to create an environment that is safe, right? That is what we're going to talk about in the next slide. That is safe not just for our patients, but is safe for our employees, for our teams. And we'll talk about that safety, that idea. Right. So this safety, when we talk about it in a trauma-informed lens, is not just physical safety. This is emotional safety. This is psychological safety. And then how do we start to look at this? How does well-being, and so this is that little piece that I'm going to encourage you to continue to look at. How does our well-being fit into these purposes of ethical standards? So how does our own professional well-being guide our behaviors? How does our own well-being guide the treatment culture that's going to support not just our patients, but our employees? How does our own well-being create an environment that is safer for us to be able to experience our own professionalism, as well as what the stage is that we're providing for our patients and for our teams? Well, became fancy for a second. Sorry about that. The professional relationship. So when we look at it, if we are looking at this from a trauma-informed care perspective, safety is our number one priority. We have to make sure that our patients feel safe, physically, emotionally, psychologically. So when I have done the trainings on trauma-informed, that is a core foundation of what we need to do in order to provide this. When we look at the emotional and the psychological and the physical safety of our patients as being number one, our interactions with our patients and with one another should foster that culture of safety, including boundaries. So when we look at it, we want to be sensitive and respectful. And again, I'm going to highlight these. For those of you that have done trainings for me, I'm not really good about sticking to my slides, but for some of these things I need to, because I'm going to be asking you to look at this a little bit differently than we have historically looked at this. Because normally when we think about ethics training, we think about this is exactly what's going on. But what I want to look at is in regard to well-being, making sure that we're sensitive and respectful. How does that get in the way for us? How is it that we go into a field knowing who we are serving and how we want to show up, and somehow we still show up differently? That our ability to remain sensitive and respectful to our patients has changed. Our ability to treat individuals with dignity and our ability to act in the good of our patients. I apologize. It feels like it might be a little glitchy, so I'm not sure why that's happening, but I'm noticing that it seems like it is. So my apologies if it is. When we look at those boundary violations in behavioral health, here's one of the first, right? So again, this becomes the foundation of trauma-informed care. But when we start looking at derogatory remarks, so we all know better, right? We know that we're not supposed to say anything to our patients. We're not supposed to behave in a disrespectful manner. So how do we get caught in a space where we are behaving in ways that we know better? Sometimes, right, we become frustrated with our patient if we feel that they are disrespectful, right? Everybody that knows me well knows disrespect is an incredibly significant word. So we feel frustrated when a patient engages in what we think is disrespectful. But the second we start feeling that way, we have personalized those comments. And so personalizing our patient's behaviors creates us to react versus respond. And so when we look at, again, how well-being is going to start playing a factor in this, when we feel depleted, when we are feeling our well-being is being compromised, and we will talk about what exactly that means, do we change the way that we respond to our patients? When we start to blur some of our lines and we have inappropriate sharing of our personal information, when we start, one of the bigger ones that I feel like everybody is aware of, right? So sexual advances made by a patient or by you. I'm not reading my texts, but this is how we're going to communicate as there's questions. So I see some questions coming through. So I'm just going to take those out for me. When we fail to respond, so this is an interesting one as well, right? So what happens when a patient engages in a behavior that we feel needs to be addressed, right? So are we communicating this to our supervisor? Are we appropriately looking at this as a behavior that our patients are engaging in and that we're doing our own touch points to ensure that we feel safe? Do we feel we are in a culture that is going to support what the needs are while not disrespecting or not compromising our ability to recognize that these are those behaviors that are being treated for a patient, even if that means we might have to transfer that patient? That when we look at planning social encounters and becoming social friends, right, that these are violations in our own boundaries with our patients, because if we think about the way that we communicate with our friends, that should not be the way that we communicate with the patient that is receiving mental care. Dignity, respect, integrity, those are all things that everybody should have, regardless of whether they're friends of yours or whether they are somebody that you're working for or a patient. But when we start to blur the lines of our relationships and you start to move into more of a friend, that does change the way that we respond. If my friends treated me or said some of the things, or my family said some things that sometimes I've heard patients say, I probably have a very different reaction than I do when it's a patient. And then clearly a very concrete boundary would be staff and patient dating, right? So that we know that you can't, right? You can't exploit a patient by engaging in a behavior. And so all of these things, when you start to look at behaviors, part of what we can also do within our own ethical standards, and again, the first part of this training is going to be basic ethical standards and practices that we are obligated to engage in. Then I'm going to layer ethical considerations when it comes to our own well-being and how some of these things that we're talking about are being impacted. but these require documentation, right? Everybody's worst nightmare when they're having to engage in treatment, right? I've heard many a therapist saying, I didn't go into this field so that I could document, but you did. Because if you are in this field, you have to document. And if there are behaviors that the patient is engaging in ethically, not only is this going to be necessary for you to document it thoroughly and appropriately for the safety of yourself, it is also critical for the safety of our patient. These are patient behaviors that they are actively seeking our help to be able to continue to support and learn alternative ways to behave that won't compromise their recovery. If it is not documented, if we don't do appropriate incident reports, then there's limited, if any, ability for us as an organization or as a practitioner to be able to change the way that we look at our environments to create an environment of safety and a culture of safety. And there is limited, if any, ability for us to be able to work with that patient to be able to change the behaviors that they're actively seeking to change. So we're going to touch on this idea of dual relationships and exploitation. So when we talked about it a little bit before, the idea of using your authority to take advantage of others is what we deem as exploitation. When we talk about some people, ECRA makes it illegal to pay or receive kickbacks in exchange for referrals for substance use treatment. It is designed to prevent financial incentives that could lead to an overutilization of services or inappropriate referrals. That would be exploitation, right? If I benefit from getting somebody in access to care because I'm going to be able to do X, Y, and Z because they're promising me something, that is taking advantage of an individual who is actively needing to have access to care and dignity and respect. When you're using your relationship for personal gain, and sometimes this has become blurry for people, where they're like, well, the patient is saying that they're going to, do my roof because they're so grateful for what we've done. No, because you have to keep in mind the power differential. In a relationship, if you hold all the cards in regard to a patient engaging in a service that they may or may not want everybody else to know, and you hold information that is unique to the position of your facility, then having a relationship where you hold them puts you in a relationship of power. That's that idea. So each state has its own licensing body and their set code of ethics. So if you're an LPC, if you're an LMFT, if you're a psychologist, they set the code of ethics for you. So I'm not going to go into the detail because honestly, they're all a little bit different. But the reality is that all of them agree in that one space. There is a power differential regarding a patient and a staff member that we have the duty to respect and protect in part for that patient. So we cannot violate their trust. We cannot violate their civil rights. We cannot coerce them or threaten them as a method of treatment. So this is an interesting one because, again, when I think of it, and it's all going to layer itself back into well-being, how did we get here? How did we get to a place that sometimes we have found ourselves threatening a patient? If you don't do this, this is what will happen to us. And so that doesn't mean to say that there are some times that a patient engages in a behavior that we need to be able to help to support because it risks the likelihood of a patient not being able to continue to receive treatment in your facility. But are we doing that as a threat? Or are we doing this as a clinical conversation? I'm going to argue, we all know it's supposed to be clinical. So is my ability to feel compromised in my own well-being when I shift from it being a clinical conversation to a threatening conversation? If you don't do this, and this is what's going to happen to you. Because that can promote shame and humiliation. And so for my teams, when I have done plenty of trauma-informed trainings and gone across kind of our organization, right, and behavioral health, when I do trainings across the country, this is where I will continue to say, if we are promoting or incidentally perpetuating shame and humiliation, then we aren't truly trauma informed to the experience. So what does that look like? It looks like we make a patient feel ashamed for the behaviors of our patient. We are treating this is not your friends, not your family. So if we shame them for the behaviors that we should expect that they're coming to actively seek treatment for, by telling them you should know better, you need to act better, you need to do better, why are you still doing this? Why are you acting this way? Then that does perpetuate shame. And we all know in the behavioral health space, shame is one of the biggest barriers to recovery. So we need them to understand the behaviors exist for a purpose. And the reason that you're seeking recovery is to change the behavior for a different purpose, right? If this is what it's solving for, let's give you some other options. And then finally, that we do not impose our own religious or political values. This is something that normally I don't normally have to say as much, but today I do, right? That everybody has the right and the dignity to be able to access treatment and recovery. Everybody has the right to recovery, regardless of their political views, their religious views, that is not something. Listen, when we are being recommended not to have these conversations on the dinner table, it is way and you shouldn't be having this conversation for a patient. We don't know everybody's political views. And honestly, it's none of our business. We don't know everybody's religious beliefs unless they are telling us that it is a priority for their own recovery. Outside of those parameters, this isn't the place. Because what we don't want to do is create a culture where divisiveness is a part of not just the staff to patient, but patient to patient. Confidentiality. So I am moving through a little bit quickly because, again, there's some staples on the whole idea of like, what is ethics, right? How do we be able to monitor the ethical standards and practices? And then again, we're going to move into well-being. I'm going to pause for a second to answer a couple of the questions. So questions, when the clinician is struggling with depression, will that be a barrier to our clients? This is a great question. We're going to get to that with well-being. If we are dealing with an alcohol or addiction ourselves, can we still keep our clients safe if we are in our own recovery? That's if domestic abuse and we are still practicing, is that a patient safety or do we inform? That one I'm not exactly sure what that is. Callie, I see you. Am I still glitchy?
Yeah, a little bit. I was thinking because I don't want to have you restart your Wi-Fi and us lose you. Um, are you open to me like raising my hand or something every time you just need to take a breath that way? Because it just lasts for like 3 seconds and you come back.
Yeah. Let me try and close some things and see if that helps.
I remember this happened at your last webinar too, but
I know. I
it's
think
so
it's me.
infrequent that it's hard to know. And it wasn't happening at all in our practice session, so I don't know.
All right, let me get rid of a couple things. Oh boy. Now I
And
need your help to see what the screen is.
it's on your editable.
Oh no. And let's
Okay,
see.
great.
All right, everybody. Apologies, apologies. Welcome to technology. All right. So when we start to talk about confidentiality, so there are a couple of questions that I think I'm going to be able to get to. Because what you're talking about is quite specifically the idea of well-being, right? How do we show up and how does it impact our work with our patients, right? And so I do want to say, because I think that this can be confusing, right? We are humans treating humans. We will always be humans treating humans. And as a result of that, we will experience human-related experiences, right? We might have depression. We might have things that we are currently or actively working through or in recovery of. And so we'll talk about how and when we should start paying attention to how is this showing up in our job. Because that's what it looks like that I'm looking at as a few of these questions. One, I am ethically obligated to submit documentation report of an ethical violation that a previous employee allowed and encouraged to staff. Yes, I think that was a question. I'm not sure if that was the question, but yes, if there is something that is occurring, then we are obligated. That's not just ethically, we are obligated to be able to document what had happened so that the organization, so that the patients and our staff are safe. That's the whole idea behind these, right? So that's the whole reason that we have ethics, is to set a standard and a practice. When we look at confidentiality, confidentiality is on a need to know basis. If it does not apply to your role, you should not be privy to patient information, right? So that goes, and again, one of the biggest questions is like, what if somebody enters into treatment and I personally know them? Then you disclose it to your supervisor that you have a personal relationship outside of the facility, and then you do not access any of their treatment. You do not access their codes, you do not get in their charts, right? And HR can be a support to that experience, because again, we want to make sure that we're protecting it. There's plenty of people, particularly today, that know somebody that's engaged in a need for service. But I always think of it in the same way that I do for trauma informed. Think of yourself going into treatment and finding somebody that you know. Would you want them to know everything? The answer is no. And so again, if we're looking at, so how do you protect that? Then that might be where you start to shift, right? And that's part of the protection. So when we look at some of the key factors of how do we protect our patients and their privacy, 42 CFR, right, part 2, is one of the primary laws that protects behavioral health confidentiality in the United States, right? It is a federal regulation that safeguards the confidentiality of substance use treatment disorders, right? We know HIPAA, again, a broader kind of protection for medical records and personal health. So these laws ensure that patients' behavioral health information is kept confidential. Subtle ways, and we'll talk a little bit more about it in a second, but subtle ways that we can see this is you're walking in the hallway, a patient comes up to you, they start to talk about themselves in a personal manner, sharing some information that is more appropriate for their own personal experiences, or they start to talk about another patient. In those moments, when you are engaging that patient, part of how you can protect a patient is to be able to start having a conversation with them of like, let's get into the oh my gosh, there we go. Okay, sorry, I'm still having technical difficulty. Why don't we go into my office so we can have a little bit more privacy? Why don't we go into this corner? It's always one of those things that I'm impressed by, for a lack of a better term. Our patients always seem to know what's going on. So when we look at like, so how does this happen, right? Patients seem to know when there's email sent out about them. Patients seem to know when there's email sent about other people. Patients seem to know personal information that they shouldn't know. And so how, if we are looking at confidentiality and the privacy of our patients, here's some key ways that we can start looking at how to protect them. So there are several high-risk areas that PHI can be exposed. So if you're not behind a closed door, or you're in an open forum having a conversation, that even if the patient started, that we are the professionals that we would want to be able to move them to a side so that their personal information isn't heard by other people, particularly if they're talking about other people as well. That when we look at poorly secured EHR, right? So if you didn't lock your computer and you walked away from it and anybody can access it, somebody can overlook it. So I'm always impressed when a patient is like, hey, how come there's so many emails about me? How come people are sending these things? And you're like, how do they always know? That is a breach of confidentiality. How they breached, these are some of the ways. So again, if you're in an organization, these are things to like highlight certain areas that run a higher risk where there could be potentially a breach. So locking your computer, having something privately printed, right? So where is your printer? Is it in an area that anybody, and again, keep in mind where we said, if it doesn't pertain to your job, then you shouldn't be privy to all confidential information. So do we have our papers being printed in areas where anybody would be able to access it? Are we sending information that doesn't say that it's confidential, right? Where the onus gets put on the person receiving it. And then in our space. Do we have our information? Do we have notes jotted about a patient? Do we have treatment plans sitting on our desk? Do we have information, any PHI that's on our desk that would easily be identifiable, not just from other patients, but from staffs that do not need to know or be privy to that information? When we look at the idea of safety first and the limits of confidentiality, these are some of the critical components where confidentiality is coming into a different realm, and that the law would require that we break confidentiality to assume safety first. So that is going to include, but not completely limited to, imminent danger, either for suicidality or homicidality, communicable diseases, child, elder, and dependent adult abuse, and then a medical crisis. And again, as we say all the time, if you are not certain, always speak to your supervisor. I'm going to say, even if you are in doubt or if you're fully confident, you still always need to speak to your supervisor to ensure that you are doing things the way that we are supposed to do and following the ethical guidelines. So just a quick kind of overview of what imminent danger is, right? So imminent threat of harm reflects the following three components. If we are doing an imminent danger assessment, again, we have the responsibility to inform our supervisor. But these things look like a strong probability that certain behaviors will occur, the potential for such behaviors to present a significant risk of serious negative consequences to the individual or the target, and the likelihood that such harm will occur in the near future. So those are critical elements. And again, I'm not going to get into great detail over some of these, but that last sentence is pretty crucial in our ability to know where our patients are. So the likelihood that such harmful events will occur in the near future. So if we look at this as an example of suicidality, and we have a patient that is expressing ideation with an intent, and the intent is that while they are in treatment, they will shoot themselves. And when you do the assessment, they don't have access to firearms. When you call home, there is no access to firearms, or when you do your initial assessment and you're asking, where they have access, if the threat is not likely to occur because there's no access to it, then we do want to still treat this as an incident that we are going to support our patient, but it might not qualify for us violating confidentiality. Hopefully you're following with that space. So those are the three qualities, or those three components in imminent danger, where we would have to breach confidentiality to ensure the safety of the individual and or those that they were looking at. So now we go into well-being. So this is where I'm going to change the direction of how we look and understand ethical principles when it comes to our own well-being. So let's start with the basics. What is well-being? Is it an absence of illness? Right? So as somebody is saying, like, if I have depression, does that mean that I don't have well-being? If I have an anxiety disorder, if I am in my own recovery from substance use, does that mean that I don't have well-being? Is well-being like my happiness as a balance between the positive and negative emotional experiences? So like if I'm happy, does that mean I have positive well-being? And is it subjective experience of life satisfaction? Is my well-being, personal relationships, my career, my health, my gratitude, like what exactly is well-being when we start to look at this, particularly as it pertains to our own ethical guidelines? So here are some examples of definitions of well-being. that we'll look at again, because it's a little bit complicated. It's a little bit more nuanced, right? There's no clear, you could research well-being over and over and over again, believe me, right? Because I have, and it will have subtle changes each time that you do it. But if we look at like the World Health Organization, so the WHO, not the band, physical, mental, and social well-being, not merely the absence of disease. Okay. Optimal health, a state of complete physical, mental, and social well-being, not merely the absence of a disease. So you can see that there's changes, right? So even within the WHO, that they were updating what that definition was. An integrated method of functioning, which is oriented towards maximizing the potential of the individual. The Global Wellness Institute, the active pursuit of activities, choices, and lifestyles that lead to a state of holistic health. Wellness is both a dynamic process of physical, mental, and spiritual optimization and integration, and an outcome of that process. So these are some of the definitions of framing what well-being is. And so I'm giving you a very broad, because this is broad, and I want you to start sitting in how it impacts you, what it looks like from your experience. And then we're going to be like, and how does it impact your ability to serve and work in this field? When we look at the views of life tasks that lead to well-being, so this idea of choice theory, right, from Glasser years and years ago. Again, there's updated versions, but when we start to look at the views of life tasks that lead to well-being, and again, I'm going to be asking you to bear with me because I want to tie this in on how this is a key component. I will say, keep in mind in the very beginning, we talked about this as a trauma-informed approach as well. When we look at some of the life tasks, our emotional well-being, so our ability to manage our emotions, our stress, and our own mental health. Okay. Our psychological well-being, our self-acceptance, our personal growth, our sense of purpose. Again, keep in mind as we do these things, how these could overplay in our work. Right. So I'm going to just give subtle examples as I do this. So if my emotional well-being, if I'm not managing my emotions or my stress or my own mental health, does that impact my ability to show up for my patients? If I struggle with my own lack of personal growth, where I feel like I'm stunted, where I feel like I'm not sure how I'm supposed to continue, where I'm not sure that the company aligns to my purpose, and I'm not sure what my purpose is, then when I show up to my job, do I show up differently? Your spiritual well-being, so your sense of meaning, your connection to something greater than yourself. Your occupational well-being, so your job satisfaction. Here's a big one in the ethical principles, right? Your job satisfaction, your work-life balance, your professional growth, your job development, and fulfillment. Does this, when it is compromised, impact your ability to show up for your patients? Your social well-being, your relationships, your connection to others, your experiences of love and what love is. Your physical well-being, which I think is where most of us think about it, right? So we think about physical well-being is for a lot of people, when I would have these trainings and conferences and I would talk about it, a lot of people felt like this was pretty much it. My health, my nutrition, my exercise, and my sleep. But that's really what they were looking at, is kind of like, hey, my physical well-being, that's really what's driving my overall well-being. And that's where they oftentimes focus their intervention. And my environmental well-being. Does my living and working conditions impact my ability to show up? Does it impact my overall sense of well-being? Does my access to community resources, such as a community that I feel connected to, friendships, right? Like all of these other areas. Do I have resources to be able to live an adequate life where I feel like I am not pinched into a corner? These would impact your well-being. When we look at life tasks of self-direction, so what do I do that directs my life as seen by well-being? We are looking at, again, so if we look at kind of like the the environment, right? Survival. So if I have a need for my own safety, for my own health, for food and shelter, does that impact me? Sure. Love and belonging. So you're going to see this over and over and over again. This is a huge thing that I continue to say within our own company, right? As well as everywhere else that I speak. Connection is key. Connection is key. Connection is key. Connection is key. So do you feel loved and do you have a place of belonging? Meaningful relationships and a sense of community. Your work, engaging in productive and fulfilling activities. Does your mission align with the mission of your career? Does your passion align to the passion of your career? Play. This is also where a lot of times people will assume that this is the area of self-care. This is the area where they engage. So allowing time for leisure, hobbies, enjoyment, and relaxation. And then growth. Growth is a fundamental need for an individual in their overall sense of well-being. What that growth looks like. It could be that they're learning how to cook. It could be that they're learning to continue in their profession. It could be that they're back in school. It could be that they want advancement in their careers. This is why when you look at organizations, they oftentimes want to create opportunities where individuals can grow within. Because it is a life task of self-direction as seen in well-being, overall well-being. So then how does it look when there's a vulnerability to our overall well-being? And what are the ethical implications to this? So a quote again, to care for anyone else enough to make their problems one's own is ever the beginning of one's real ethical development. Think about that. So how do you care for somebody else where you are helping them within the problems of their own without seeing yourself as separate? So sometimes I might hear these subtle language of an individual where they will say, I'm protecting the patient. This isn't healthy for them. This isn't good for them. I don't want them to call this person. I don't want them to call their family. I don't think that they should go to their recovery house. To care for anyone else enough to make their problem one's own is the ever beginning of one's real ethical development. So how do you help an individual work towards the life that they want, not the life that you want them to have? So when we think about this, what happens when we don't manage our own well-being? What happens when we start to do for the patient? And here's how you'll know that it's impacting you, right? Because you'll start to hear yourself or somebody else say these words. I'm working harder than them. And we think that's a patient problem. I'm going to encourage, if we look at kind of like, how did you get there? Because so go back to the beginning, right? That we're not trying to shame a patient's behavior. And again, I'm not shaming anybody that says this, right? This is why we learn and grow. This is why we're doing these webinars. This is why we continue education. This is why you highly recommend that if you're in the world of behavioral health, you are an eternal student. I do research every day. I read every single day, right? We are eternal students when you work in the field of behavioral health. So this is not to shame anybody for the current experiences that they have. This is to highlight and bring awareness to the possibilities of, does our ability to care for ourselves impact our ability to care for someone else? When we think I'm working harder than them, and we are angry at the patient for this, is this more an indication of this exact quote? Our own ethical development starts with those kind of questions like, I wonder why I feel that way. I wonder what is going on, that I feel the need to rescue someone, and this person is showing up in the way that I expected them to show up, which is to access care, to learn new behaviors, to move through their own development. So when we look at what that means, again, it's important for us to highlight And then at 11 o'clock, I'll give a 5-minute break in case somebody needs to run to the restroom. I'm going to try and figure out my computer again, get a glass of water or a cup of coffee or a cup of tea. But just so everybody knows. So when we look at a society in pain, I do want to cover these next couple of slides so that we can kind of get into it. Because I think, again, it becomes incredibly important for us to realize that today we are in a different world. Today, some things have happened. And we are the recipients of some of those things that are happening, not just our patients. So I always say to our own internal teams, right? Our patients are always our patients. Our patients are the same, right? We are bounded by, you're about to get a training on ASAM, right? So ASAM and locus, for those of you working in the behavioral health, you know, we are bound by the obligation of ASAM and locus to generate what is the most appropriate level of care on that particular person based on where their needs are. So our patients are always our patients. But if the society that we are living in is in pain, then we are different. We are showing up much differently today than we have historically. So when we look at the rippling effect of substance use, again, I've been in this field for 27 years. We've seen some of the largest amounts of loss of life over the last few years than we have ever seen. More than 46 million struggle with substance use disorder, with only 6% accessing care. That when we look at the overdoses, in 2021, 107,000 people lost their lives. So think of the rippling effect of that. Because that means that not only are those individuals impacted by the loss of their own life, think of how many family members, think of how many friends, think of how many communities. This is where, when we look at it, this is where we start to see a society in pain. And that society is us. We have a new generation that is impacted by trauma, by substance use, and by a mental health crisis. That we know. When we look at this from a mental health perspective, during August 2020 to February 2021, the percentage of adults with symptoms of depression or anxiety increased from 36 to 41%. That is almost 1 out of every 2 Americans. As of 2023, the mental health issues in America have continued to be a significant public health concern. 1 out of 5 has experienced mental health each year, around $53 million. We're seeing an increase in anxiety, an increase in depression, and we're seeing it in our youth. So I work a very long time with adolescents and young adults, hands down one of my favorite populations of all times. What we sometimes miss with this is that for any of you on this call that is a parent, if your child is struggling with a mental health condition, then you are too. So when we see that our adolescents and our children are being impacted by mental health crises, then so are their families. Because there is nothing scarier than the person that you love more than anything in this world. When they struggle, you struggle. So these are the continued rippling effects of us showing up to do our jobs. When we are in pain, how are we showing up? When we're not sure where our well-being is, how do we help somebody else with theirs? These are the questions that we're going to be kind of looking at. And then when we look at death by suicide, we're looking again at an increased rate. So a total of almost 1,700 more suicides occurred in 2021 than 2020. And in 2022, there were approximately 48,000 reported deaths by suicide. We're seeing it in children at ages that we've not historically seen. So we are a nation struggling. We are a nation in pain. The beauty is that we have each other. We have the ability to be able to support one another. But do we understand how this impacts our well-being? I will say, I was talking to Callie earlier and had said, you know, the irony is that sometimes things are put into your life for reasons. And my having to do this training at this particular time was a wonderful reminder for me of making sure that I am managing my own well-being. which is what we all need. We all need to be given the grace and the space to be able to recognize that I need to work on my own well-being in order to better serve those that I'm serving. I need to be able to attend to it, but I actually need to understand it first. And so when we come back from the break, we're going to talk about the impact on the workforce and then how do we manage it. So if there are additional questions, so I'm going to hit mute for a second. You're going to see some changes in my screen because I'm going to try and fix it. But if you have any questions, then please put those through. I know that there were a couple. I'm going to get to those in a couple of minutes. But let's take, it's 11:02, so let's come back at 11:07. So we're going to start with the impact on the workplace. There are some great questions coming in that I'm going to start with. There we go. So when we look at workplace mental health, a growing focus on mental health in the workplace has emerged, with many employers offering resources and support to help employees with their own mental health challenges. So we're going to talk a little bit about that and what that means. But I want to start with the questions because I think this is where it's coming in. So when we talk about risk for impairment, so when we start looking at that, a study that was done in the Journal of Affective Disorders, right? So again, I'm a big nerd, so you see it on the bottom of research, found that mental health professionals reported higher levels of anxiety and depression as compared to general population, and that the prevalence rates for anxiety in therapists were found to be around 25%. So when we look at 75% of clinicians have experienced significant distress in the past 3 years. 60% have experienced clinical depression, 25% of psychologists reported having experienced suicidality. Rate of suicide in psychiatrists is nearly double of that of other physicians, right? Higher divorce rates among psychiatrists, higher substance use. So all of this comes to say, what's happening to our well-being? We're going to talk about the ethical principles, but what's happening to our well-being, right? Are we attending to it? Do we even notice it? Right? I'm going to talk about something called a microstress in a second, but look at where we are. This is not to say that we are not in the profession that we should be. There is no doubt about where I am supposed to be in this world, and it is in the behavioral health space. But do I have an ethical obligation to pay attention to the overall wellness and well-being of those that I'm working with, right? My colleagues, my team. And do I have an ethical obligation to make sure that I'm attending to myself? That's really where we are. So we know that this is happening, right? We are bearing witness to the pain of others. That is essentially what we are as individuals working in this field. Do we have additional vulnerability? So when you have somebody that's saying that, I have struggled with depression, right? Is that a barrier to my clients, which we will get to? If you are actively struggling with an active substance use disorder and you are practicing in the substance use field, that I think is going to need to be a conversation, because that feels like it would be a difficult piece, not just for your own ethical principles of, am I in a position to be able to continue to serve somebody else? But I'm going to ask the bigger question. Are you in a position to help you? Because if we aren't in our own state of well-being, how are we able to show up for somebody else, right? We know the subtleties of our triggers. We know the subtleties of our experiences. And so if we are actively struggling with our own personal experiences, does it impact our ability to show up as somebody else's? That is the ethical question, right? These are some of the nuances that we need to be able to talk about. Here's the realities of our care. Our clients, our patients have difficult challenges. They are complex. If they have experienced trauma, they are not easily resolved. They require time and commitment. And I will argue behavioral health has shifted where they think that the responsibility sits. So if you work in an inpatient, you have been likely taught that you had to do all of the work while they were in a 30-day treatment facility, which bears a burden for the patient and for the staff member of, am I supposed to solve this in 30 days? Right? So my team is hearing loud and clear, no. In a 30-day treatment facility, we are in this position to be able to help the patient to recognize that they are here, to be able to provide them some support, to be able to understand the next steps that they need in recovery, right? Recovery is a journey. It is a marathon. And if you have ever trained for a marathon, FYI, I have not, but if you have ever trained for a marathon, you know you don't start off the training by running full speed for the entirety of a marathon. You start off with the right training and the right information and the right education and the right tools to be able to begin your light jogs, to be able to begin your runs, all of these things. And so when we look at our patients are complex and not easily resolved, we have to be able to understand the need and the necessity of a full continuum. You are not going to solve 30 years of trauma or multi-generations of trauma in 30 days. You need to be able to recognize that, and so does the patient. That full continuum, that is the criticalness of a full continuum, because you are learning a marathon. And you can't set our patients up to run a marathon the second they get out 30 days later when they are still wearing flip-flops, never having run a day in their life. So we have to shift it. Clients' change may not move as fast or in the way we would prefer. This is, again, putting our expectations in the space of our patient's abilities. If you are expecting that the patient is going to sustain long-term meaningful recovery from one time in 28 days of treatment, then you have to question yourself. Am I putting the wrong expectations on myself and our patient? And whose well-being does that impact? You could argue both. That empathy is supposed to be one way. When it's not, that's typically a violation of our own boundaries, right? So when empathy is coming from the patient to us, that is typically a boundary violation. Our patients should not be taking care of us. It should be the other way around, right? Our empathy should be leaning towards them, not them leaning towards us. But as a human being, that feels uncomfortable. And so sometimes what we see is in behavioral health that practitioners will engage in relationships where empathy is reciprocated. But our patients shouldn't be responsible for us. That's not how that goes. Success is not straightforward. So how are we measuring it? Having worked in the substance use field for a very long time, success is oftentimes measured by the substance. But what if the patient is still struggling with the substance, which is the hardest thing to remove, but starting to do really well with showing up for their medication and starting to show up for all of their therapy sessions and starting to work on their family relationships? How are we defining success? And many in the field, which is what was already brought into the question, many in the field already have their own adverse childhood experiences. They have their own traumas. Many in the field might be in their own recovery from substance use, from depression, from anxiety. And so we have to be able to recognize those realities and care to be able to look at, so how I show up? How is it an ethical consideration for what do I need to do for myself in order to continue to show up for my patients? And is that an ethical consideration? Here's the realities of the system. So when we work in the field, the system, again, I've been worked in this field for a very long time. These are the consistent stress points: caseload size and management, documentation, managed care, supervision, abstract knowledge versus competence. I like to call that anecdotal, right? So I think the patients seem to love this. They love it when we talk about our feelings, really, really strong feelings in the first 5 days of treatment, right? We love that they break down. We love that they're crying. We love that but is that an actuality of their recovery? Or is this just an experience where a patient that is already very vulnerable in their emotional experience has been brought to another space that they don't know how to get out of, right? So we have to be able to look at, is that abstract knowledge, like anecdotal information, or is this actually a level of competence? Are we measuring it, right? Which we're going to get to when I do my training in a couple of months. And what are the organizational expectations? What's your resources? What's your time off management? What's your coverage? How do you have that? Because that all goes to the realities of what it's like for us to be in our own system. So there is a new question. Would we consider mental health and medical providers struggling with their own SUD an ethical concern or issue? So these are some of the questions, right? The ethical considerations that we should ask ourselves. Is it an ethical responsibility for us to understand our own well-being? Now, that does not mean, so keep in mind what the definition was, that does not mean an absence of. It means along with. Can you have well-being when you have a history of depression, anxiety, history of substance use? Right? What are we doing to be able to manage it? And again, we're going to look at so what are the signs when we start to think that we're being compromised, right? And then how do we do it? So it is not the absence of illness. That is not what well-being is being defined as. According to the statistics on risk and impairment, it is written in ethical principles that we should have rest day for our own well-being. Is it written in ethical principles? I do not know if it is written in ethical principles that we should have a rest day, unless they're calling that our weekends. And then we have two, due to hearing and helping so many clients. So we're going to talk about kind of how we be able to manage our own. I have not seen anything. I think where we're seeing organizations coming in with more resources, right? Their EAPs are coming in more to be able to provide additional support for mental health crises. But how do we take advantage of what we're doing? Because I'm going to argue, and again, I'm a human being treating human beings as well. And so I have probably also been lax in my ability to recognize what I need to do for myself. So when we look at the scope of what well-being is, are you only looking at a couple? So do I think that it's written in there? I don't think that it is, but I could be wrong. So don't quote me on that one as a fact. But we have our days, and how are we utilizing our days to be able to address some of our own well-being? Because we all do this because we love it, right? So I want to make that clear. We're all in this field because we believe in the vision and the hope of transformation and recovery. That's quite literally why we all are in this field. We believe in the possibility of hope. So if we are human beings being human beings, do we have an ethical obligation that when our days are harder, are we different than somebody that might be serving in a different profession? That when they have a bad day, my brother's a CFO, if he has a bad day, I don't know if he has the same consequences as if I do, right? So those are conversations to be able to explore. When we look at stress versus micro stress, so this is a very interesting thing because we all understand what stress is, right? I think we've had a lot of conversations about what is stress, how does it impact you, how does it look, right? How does it show up? What do you got to do for it? Right? It's big, it's visible, it's obvious, it's your workload, it's patients themselves, it's my home life, right? I have, my kids are doing this and I've got this as a difficulty, it's my health, right? It's personal things, but oftentimes big and visible. How many of you have heard the conversations about micro stressors? Because these are way less obvious. So again, for those of you that have ever done a training with me, you know I love myself some brain work, right? I'm a brain-based person because I work in a field where people have continued to marginalize a disease and a disease of the brain, whether it's mental health or substance use. And so when I talk about the brain, I don't have to talk about somebody's personal opinions, right? So again, go back to like, is this anecdotal or is this factual? So I'm a huge brain fan. I talk about it every time I do a training. So this is very interesting when we talk about it within micro stress, because these are way less obvious. So think of, we already know the stressors that are in our lives. Many of you could probably list your top 5 stressors right now that you are experiencing today. How many of you know what your micro stressors are? Can we understand or can we underestimate things that are going on in our lives because we just think it was like a little bit of a bump? It's like a little bit of an aggravation that we barely recognized anything that's even happened, right? So it's a slight from a coworker. It's the feeling to protect. And so I will share that I have seen this show up, right? When we don't have a culture of safety, sometimes what you see is your teammates feel the need to protect a colleague. That can be a micro stressor because you think of that is where you add something to the individual, right? If they don't feel like they're being recognized. If you are working late consistently and you're like, it's just a part of our job. If you are missing gatherings because you had something that you needed to do because there's a responsibility, right? Our careers require certain things of us and we have to get these things done. And now you feel guilty about it. These are small examples of micro stressors. And the thing about a micro stressor is that these fall under our radar that we don't even acknowledge that they're happening. But here's what happens to our bodies. It still activates the fight or flight system. It still releases adrenaline and cortisol. It's still preparing your body to an experience of needing to prepare for something happening. It is a physiological experience. So under this constant stress, here's where we start to notice these things. When you're like, gosh, I got a lot of brain fog. Like I feel like I'm like constantly walking around. We used to think that was all COVID related, right? But then you start to recognize like, nah, I have like, I feel like I got brain fog. I feel like I'm having a hard time figuring out what's going on. Because when we're under constant stress, the working memory is impacted. And it makes it a little harder to track things that require our attention. So when you think of these big stressors, and again, this was a great example that was provided. If you think of a raging storm and the impact that it has, like let's say on a mountain, right? A raging storm comes in, right? And it is going to make a huge difference in the structure of that mountain, right? It might knock down trees, it might knock off the tip of it, it's going to impact it because it was so strong. Those are your stressors. When you think of the micro stressors, which are often unmissed, this is the constantness of wind. This is when it's constantly being barraged with the experiences of the elements. Mark my words that when you have constant wind on the mountain, it will also change the mountain. This is the microstressor. So we might feel that brain fog because it's making us harder to track things that require our attention because our working memory is being impacted. Because when our brain is slowly getting taken up by these in space by these microstressors, it impacts our ability to pay attention to tasks or solve problems like normal. So again, I am a huge fan of making sure that people recognize, right? It's literally the curriculum that we created at A Promise. Recognize, regulate, and respond, right? It is so critically important for us to be able to recognize things because when we don't recognize it, we blame it on other things. We blame it on like, oh, well, it's just this. It's just that. I just can't remember. I'm getting older. This is what's happened. I just had a, but when your brain is being slowly taken up by these microstressors, it does impact your ability to pay attention. It does impact your ability to solve problems. And now, here's where the ethical dilemma is. So how would our ability to not be able to solve problems like normal, to not be able to pay attention to tasks, how does this impact our work with another human being? Is it an ethical responsibility for us to pay attention to these because it's going to impact our ability to help our patients solve their problems and for us to be able to attend to their needs? Does it become about us? These are the questions that I'm going to encourage you to ask yourself. Because our working memory is impacted, we might not notice why we are feeling out of sorts. So we don't notice to take care of them. So in the same way that I say this, we do this with our patients all the time. We do it ourselves. We only notice when we are in crisis. We only notice when things are getting so difficult and so bad. But that's been brewing. So how have we been showing up when these things are impacting us all of a sudden at the end? So if we don't notice these things, then they have likely impacted our ability to show up at work. So we didn't know to care for them, right? We waited for like, oh, this was like a really difficult day. Oh my God, I was so overwhelmed. And so I'm going to engage in some act of self-care. So I'm going to, but what about these daily ones that are slowly impacting, right? The wind that is changing the shape of the mountain day after day after day. So here's how we see the warning signs. So when people are saying, so how do I know, right? So this is the question that I'm getting, right? So how do we know? If I have depression, how do I know if I'm able to continue to work with my patient? If I'm struggling with this, how do I know? Because the brain is going to tell you. That's the beauty of the brain. So when you start to find yourself, and that's why I've been poking at some of the areas of like, this is part of well-being. This is part about well-being. Does this apply for some of the ethical considerations of if we are impacted, do we have an ethical obligation to engage in some things to be able to get our own well-being better, to be able to service others? Does this profession require something different as an ethical guideline for us to be able to show up for our patients differently? So you might notice it when you're agitated. You might notice it when you are having difficulty managing your emotions, when you are dreading going to work every morning, when you are feeling exhausted before you even got there, when you are frustrated at your patients, when you are lashing out, when you are reacting to your patients as opposed to responding to your patients, when somebody says something to you and you are more frustrated with their thoughts and the fact that they're doing it. When I heard a clinician once who said, I'm so tired of this patient making the same decisions over and over and over again. I don't want to do this anymore. Oh, your well-being. So those that I have supervised have heard this all the time. They probably regret hearing it from me all the time, but they would call me and tell me that they were having a bad thing or the patients are all acting out. And if there was somebody on this call that had me as uh, that I had supervised, they would be like, yeah, she did used to say that. I would literally start by saying, so what are you doing for yourself? Because your patients are always your patients. What are you doing? What do you need to do differently? Because you're changing and you're a human. It's okay. This is what we need to do to support each other. But your patients are your patients. So if you are feeling more punitive, if you are angry at a family member who is calling relentlessly to get access to the information regarding their loved one, and you are angry, ah, what are you doing for you? Your well-being is being tackled. And you are a human being, and there is no shame in this game, but you got to notice it. Why are you angry at a family who is afraid that their loved one could die? Why are you angry at a patient who is presenting the behaviors that they're accessing care? I'm not angry at you as a staff member, but my gosh, is your well-being being compromised because now I'm worried about you. Now I want to care for you in a way that says, pay attention to you. You have to do this because we are in a field that we don't get to sit at a desk. If my brother, who is a CFO, has a bad day, he can't change the numbers. He's just sitting grumpily at his computer, plugging away information. But we have to show up. We have to be a human to a human. And that human has excessive needs that we have to be able to support. Because that's why they came to us. If you are having increased sadness or feelings of loneliness, if you are enjoying life less, noticing this and noticing that you are in your limbic system is going to help you to recognize you don't need to be all the way in the crisis for you to be able to start paying attention to the micro stressors, the actual stressors, and everything in between. You need to start engaging in deposits. You need to look at your overall well-being and see where you can make a difference. It's physiological, right? You're not just going to be able to talk yourself out of something. It's quite literally physiological. So when we look at warning signs of those micro stressors as leaders, and we're all leaders, right? No matter if we're leading ourselves, leading our families, or leading a team, we're all leaders. We need to be able to look at our capacity to get things done. And if that has diminished, if the disruptions to the internal well of your peace, of your fortitude that helps you to stay focused and prioritize and manage conflict, if that's being disrupted, you need to notice that with your teams and you need to notice that with yourself. And if it's impacting your sense of self, because again, keep in mind, we are in a profession where we believe in the possibility of hope, where we believe in the possibility of change. So when you start questioning whether somebody actually has the capacity to do that in somebody else's journey, it is a micro stressor to your sense of self. Because you didn't enter this field assuming some people are never going to get better. You entered into this field because you felt that there was the ability for individuals to begin their own recovery. And so when we lose ourselves, when we lose that sense, we start to lose ourselves. And that is one of the cores of our own well-being. So we have to be able to pay attention to those things. That's one of your signs, right? We're looking for something global, like these big things that are like, oh my gosh, all right, so that's why I act this way. That's why I act this way. That's why I act this way. But sometimes it's just that you're like, why am I angry at these patients? Why do I feel like they need to behave differently? Why am I taking this personal? Why do I think I'm working harder than a patient? Why do I think that patient owes me something more than they've owed their families, the people who they love more than anybody in this world? Am I feeling distressed? Do I need to attend to my well-being? That's the ethical question. And is this the ethical implications? Do we owe it to ourselves and our patients to do this differently? Is that an ethical consideration? So the professional quality of life, again, professional quality of life, we have compassion satisfaction, right? When we are showing up in our own well-being and being able to access our care and to be present with our patients and feel alive and feel rejuvenated and feel like there's opportunities for growth and our passion is aligned to their mission, right? All of these things. Or do we feel compassion fatigue, which leads to burnout, which could also lead to secondary trauma? Do we feel that? And is that an ethical responsibility for us that when we say, I do actually feel these things, is it an ethical responsibility of ours to attend to them? Or do we just keep plowing through and showing up to do our jobs despite feeling that? So just a very quick overview of compassion fatigue, feeling someone's pain versus seeing their perspective. Let me say that one again. Feeling someone's pain versus seeing their perspective. So when you feel, oh gosh, this person really shouldn't have their family involved. This person really shouldn't have these things involved because they feel like that. Seeing their perspective is, my gosh, this must be so scary for you to have to reconnect to your family after everything you both have been through. That makes a lot of sense that you're afraid to make a phone call. Feeling someone's pain, which is going to lead you down to compassion fatigue, is, oh my gosh, I have to protect my patient. Like their family is horrible. This is terrible for them. They shouldn't be doing these things. And you can replace family with anything else, but you are now responsible for that individual and you can't protect them from the world that they're about to live in. There's the difference. Then when we talk about vicarious trauma, right, do we ingest the experiences, right? Again, we're human beings treating human beings. This could be isolated or it could be accumulative. That when you are attending to somebody else and not attending to yourself, that accumulation will start to move you towards compassion fatigue. I've done a whole training on compassion fatigue alone, right? Our ability to recognize it within ourselves and then our ability to be able to manage it so that we can show kindness and grace to ourselves and the same dignity and respect that we want to show to our patients, that we start with ourselves. But you can't muster your way through it. You don't just show up anyway and be like, I got all this stuff that I'm carrying all the time and think you are the same. You're not. There's no shame in that game, but you got to recognize it, right? It can coexist with burnout. So then what's burnout? That's the occupational stress. We hear this word all the time. Some people love it. Some people don't love it, right? It becomes frustrating. But burnout is the physical and mental exhaustion associated with a loss of identity. Here's the thing. Burnout is when we are not caring for ourselves. We will oftentimes assign burnout to the operations, to the company, to the person that we feel is doing it to us. But burnout is an internal process because we have done too much and violated our own boundaries. That's where burnout is, right? And so you want to be able to support, you want to be able to support one another. You want to have an organization that's going to be able to recognize like, hey, let's have conversations. Let's look at some of these things. But burnout's going to impact your belief about your worth and your productivity. But this is an internal structure that we have to start looking at. And again, we're going to get to well-being and why that becomes so critical. So here's the causes of burnout: unsustainable workload, perceived lack of control, insufficient work, rewards and effort, lack of supportive community, lack of fairness. Fairness is a big one. But although these are organizational issues, self-care is your cure. These are a part of it, right? Unsustainable typically means that we just feel things are changing. We feel overwhelmed. We feel like this is too much. I feel like I got no control. I feel like I'm not being right. It's all of these things that you're looking at that, again, it can be brought through an organization. A great supervisor can help in supporting that. But it also is an indication that you got to start taking care of yourself a little bit differently so that you can continue to show up. Here's your tipping point. Here's when you know that it's all the way over. Your own performance expectations have changed. You start to isolate more, right? You go home and you don't want to be around anybody. You have a self-appraisal failure. whether it's suicidal thoughts, whether it's a reoccurrence of your disease or a relapse, whether, right, your judgment is not accepting to admit nothing left to give. You feel like you're missing the mark. You start to feel overwhelmed with the responsibilities of your ethical guidelines, confidentiality. So when you look at this and you think of like, so how is this impacting your well-being? And we talked about like those core elements of well-being. How are these things impacting your well-being? And how do you get it back? How do we get it back in a demanding environment, right? I remember I had to do a training on trauma-informed care, and actually it was on it might have been the one on compassion fatigue. And so everybody in the room had to go around and talk about it. What's your practice of self-care? What do you do for self-care? Um, And it was a couple of attorneys, right? So I think I was doing it actually for the district attorneys. So there were a number of individuals that when they run around and some of them were saying, I don't have time for self-care. I don't have and self-care is a very catchy phrase and people do or don't love it, right? So it has all these implications. But there was a lot of attorneys. So these were public defenders. Let me say that. These were public defenders. And a lot of them that were saying they don't have the time, right? This is the struggle. This is the system, right? Like, I don't have the time to do it, blah, blah, blah. And they got to me and I said, I don't have the luxury of not doing it because my day impacts somebody else's day. And actually, if you're a public defender, I'm going to argue you don't have the same luxury because your bad day could be the difference for an individual to being incarcerated versus accessing treatment. And so this is where I go back to say, is it the ethical obligation of us to be able to understand our well-being so that we can continue to show up? Because my bad day, if I have a really bad day and I show up in a system and a patient says something to me and I lash out and that patient leaves against advice, it's not my responsibility. Let me make that clear. We are not responsible for other people's behaviors, but do I have an ethical obligation to care for myself in a way that allows for me to show up where I don't personalize my patients, that allows for me to show up when a patient has their bad day, that I can sustain it because I'm here for them, they're not here for me. Do I have an ethical obligation? I, Trish Caldwell, feel like I do. I have an ethical obligation to make sure that I am well enough in my well-being to show up for our patients. This training is about asking all of you to ask the same question. Do you have an ethical obligation? Because for those attorneys, my opinion was you do. Because you show up with a really bad day. Do you change your ability to advocate and fight for a person that could end up in the prison system? And their answer was yes. This was why they were asking for a training on well-being and self-care. Because they were trying to figure it out because we keep doing it wrong. We keep telling everybody needs to do the same self-care. But when we look at in the field of mental health, we are not just healers. We are the companions on the journey of recovery. So we have to be able to model what it is that we're saying. So how is our well-being a question of ethics? The relationship. The therapist is the model for health. Does my relationship change when I'm having a bad day? Does my relationship change with a patient if the patient is actually triggering me, reminding me of my own family member? Do I get more frustrated at some patients based on their race, based on their culture, based on their gender, based on their identity? Does my relationship change if I feel like that patient is more disrespectful versus this patient? Do I like some diagnoses better than other diagnoses? If my relationship changes, right? You hear people saying it, right? Oh my God, we all love that patient. We love that. Do we have an ethical obligation to recognize, should I like my patients more than others? And again, you have your own internal feeling, right? It's just an indication. Like, can we look at it as an indication? I don't like this patient more, but this patient provides less pushback. That feels easier for me as a clinician. And so that is different than a patient that has 3 generations of trauma has an inability to understand how to establish trust and engages in behaviors that have been incredibly protective for them for the last 30 years, can my relationship still be professional in that I see those behaviors as their struggle versus seeing the behaviors of the individual that I think is easier? Do I have an ethical obligation to look at that? As opposed to putting it out onto the patients where I say, one patient is good and the other patient is difficult, right? They're so hard. Do I have an ethical obligation to make this more about where I say, I wonder what that is about me? I wonder what it is about that patient that I struggle with. Am I feeling overwhelmed? Is my well-being being taxed? And I just find it easier to work with some patients because it doesn't require more of me. Because that would be okay, because we are humans treating humans. But do we have the ethical obligation to look at it? Our ability to show up. So here are the professional ethics. So when we look at it, impairment, counselors refrain from offering or accepting professional services when their physical, mental, or emotional problems are likely to harm a client or others. They are alert to the signs of impairment, seek assistance for problems, and if necessary, limit, suspend, or terminate their professional responsibilities. So these are professional ethics of conduct for professional competence. So this ties in to what we have talked about. These are some of the ethical boundaries. So how do we recognize it when we get off balance? Right? So we are always a seesaw, right? So somebody asked me once, I'm gonna have to start moving a little bit faster because we have about 15 minutes left and I want to make sure I get to everything. So somebody asked me once to do a training on work-life balance, which if you know me, you know that's a funny question, right? Because people think that work-life balance is a 50-50, right? How do you keep it so that you're 50% at work and 50% at home? And the reality is that that doesn't exist, right? Certainly not in some of our professions. But can I go, if I went from a 70-30, can I make sure that that seesaw continues to balance, right? That there's going to be some weeks that require a lot more of me and I'm off balance for a little bit, but am I able to recognize that I'm off balance and then make sure that when I'm going the following weeks, that I get that seesaw to tip a little bit, that I might have to take a little bit more time to be able to spend with my children, or I might have to do some of these other things, right? So work-life balance isn't 50-50. It is a seesaw and knowing that that's what you're on and figuring out ways to do it. But if you start looking like this seesaw where everything that's being impacted, your work is a stressor. You have less time with friends and family. You're moved away from your mission because you don't feel so connected to your job. Where your eating has changed. You're not sleeping well. And the only thing that you're doing for yourself in your well-being is like going to church and engaging in one act of self-care. You're like, I still get my nails done. I'm like, that's not going to work. That's not a balance. So if you have some of this, if the left side is continuously happening with no end in sight, then you're going to remain off balance. Your well-being is going to be impacted. You have to be able to recognize that and the freedom to it, right? Because again, I like to say I'm a little bit of a type A. So for somebody telling me you need to be 50-50, that set me off balance because I'm not going to sacrifice one versus the other, but can I look at it and say, okay, I need to invest a lot of time in my work right now because there's these things that are going on, but then I'm going to make sure that I take my time off, right? So how many of you don't take your PTO? How many of you are just saving it for one lump chunk where you're like, I'm going to use all of these things, or I'm going to, how do we do these things in these little micro doses of engaging in some act of well-being? Otherwise, our seesaw is going to permanently be off kilter. So then the well-being tank. So when we start talking about that, we're going to go back to what we talked about, that the essentials of what well-being is. Are you managing this? Because what I had said to you earlier is oftentimes when people start to feel overwhelmed, where their satisfaction is decreased, where they feel burned out, they only go after their physical well-being. So they will change. So their acts of self-care are going to be, I'll eat healthier, I'll start to exercise, I'm going to work on my diet, and maybe I'm going to get my nails done. But what about these other areas? Because you are a whole person. So are you managing your emotions and stress? Are you recognizing that you're more impacted today? Do you recognize that these micro stressors have impacted you and you are feeling more overwhelmed? You are feeling that brain fog. You are feeling the inability to stay problem focused. Are you struggling with your sense of purpose? If you are in your career and you're questioning, I don't know if I'm aligned. Like I want things, but I'm like struggling. Like I don't know why I'm angry. I don't know why I'm showing up to my patients. I don't know why they're frustrated. I don't know why I'm now angry at our patients for being patients. Then how do you attend to that? How are you making sense and meaning of the work that you're doing? Do you have job satisfaction? Because every person in the entire behavioral health space serves a purpose and is equally as important to the experiences of our patients. I don't care if you're a therapist, if you're a CEO, if you are the housekeeper, if you are a recovery support specialist or a behavioral health technician, if you are a chef, your role is equally as important in the purpose of the work that we're doing. And if you feel that you're not being understood, that your job is being marginalized, that your work life, then how do you rectify that? How do you see your professional growth and importance within the job that you are wanting to fulfill? Your social well-being, what do your relationships look like? How are you managing them? Do you feel connected to others? Because when your relationships are getting strained, that typically is oftentimes when you come in and you're more frustrated with your patients' relationships. This is where that blurred boundary is, right? All of a sudden, do your patients start to become more of a friend, where you're having conversations with them because you've been disconnected from professional or personal relationships? So we have to look at that. And then back to your environmental well-being. Is your living and working conditions impacting your ability? So well-being versus self-care. So a very quick kind of overview of the difference. So well-being is the broader concept that includes various aspects of life, which we just talked about. Self-care is specifically on the actions taken to nurture those, right? So when everything else seems to be going against you, remember that the airplane takes off against the wind, not with it. So in the midst of some of the things that are most difficult, how do we successfully take off? Self-care is an ethical obligation. So again, competence is the essential link between ethics and self-care. Taming the brain. So I'm going to start with some very kind of quick and overview of recognizing it. So again, I told you I'm a brain-based person, so I believe in the fundamentals of understanding our brain to help us to be able to move through this whole practice. When we are in prolonged stress, so big stresses, prolonged stresses, micro stresses, the alarm keeps on ringing, right? That's that whole fight or flight. When we are activated, this is the whole idea that we can't access the rational parts of our brain. That is your working memory, that is your problem solving, that is your ability to think through the consequences, all of those things. And so in order to shut off the alarm, we have to be able to regulate. Sometimes we try to be too rational first, and we just need to be able to regulate. But I'm going to encourage you, consistently regulate. Not just regulating when you're in the most distress, because that's a harder time to regulate. What are you doing daily? What are you doing daily? So there's two different approaches. We teach this to our patients as well as I recognize this for myself. There's a top-down approach, right? So cortex first. That's where when you're kind of dysregulated, when you're kind of questioning it, right? When I'm like, man, that was a hard day. Did I make a good decision? Was this the right thing for me to do? When I'm able to actually consistently problem solve, I can do that, right? Top down of regulations don't work though when you're in high activation and distress. So this is the importance of you learning where you are within your micro stresses. This is an importance of you learning because when you start to get into that crisis mode, when you're showing up to work and you're already agitated, when you're dreading the day, when you have a certain patient that you're already frustrated at, then you are in a different part of your brain. And top down is going to be less effective than a bottom up. You got to soothe it first. So when you are doing that, that might be your mindfulness. That might be some of the other acts, right? That might be where I do breathing. That might be where I take a walk before I go into work. That might be that I do quiet meditation with some music that I love. You're going to need to go after the lower parts of your brain first to be able to get to that rational. How do you know when you're there? Because when you try to tell yourself, like, Trish, you're doing the things, this is the right thing to do. And why am I questioning these things? Why, when I can't get out of that place, That's because I'm much more distressed than I thought I was because the rational part is trying to turn on. It's like trying to turn a light bulb on, but that the light bulb isn't fully functioning. So you keep flicking it and it's like shows up and then it turns out. You got to go into a different room with a different light bulb. You got to go at the bottom first to be able to get to that top. So the beauty of your brain is that when you start paying attention to you, it's going to give you all kinds of clues. That's the beauty. That's how you know. When you are trying to rationalize with yourself and you're beating yourself up instead, you're in the wrong place. Do a bottom up, not a top down. So the strategies for self-care. So these are all the strategies, right? We all know them. I'm not a huge fan of like just talking about self-care because everybody knows what they are. So it's important for you to recognize what is yours, right? If you're an introvert, here's the thing. I always say this because ironically, I am an introvert. So my self-care methods are much different than my extroverted friends. But if people don't recognize who their personalities are and what they are about, then they try to engage in self-care that's not effective for them. So you need to do small things. You need to be able to look at mindful practices that work for you. How do you want to engage in nutrition? What does exercise look for you? What are the connections? What are the relationships? Because research is saying not only are the connections important, but connections in various parts of your lives. So if you have like a good set of girlfriends, and then you have a good set of work friends, and then you have your family, and then you have, a community support group or where you volunteer, right? Or your AA groups or your sponsors, right? Your home groups, all of those having multiple connections shows the most improvement for actively engaging in self-care. I know I'm hurrying. There's a couple of questions. I'm going to get to them. I'm not ignoring them, but I want to make sure I hit some of these. So when we look at the workplace stressors, so why do we need to do this? And if you are in a position that you supervise or you are a director or you're doing any of these things, it's important for us to look at this, right? So 40% of our staff is experiencing the job as stressful. 26 endorse burnout. So it's important for us to look at this, right? It's important for us to attend, not just from a human perspective, but also to be able to continue to have our patients be treated with individuals that are paying attention to their own well-being. So your relationship as a supervisor is incredibly important, or your relationship with a supervisor is incredibly important. So how are we monitoring it? How are we looking at it, right? So again, sometimes with my team, I will say, I hear what you're saying, but I actually need you just to disconnect. I know you want to do this, but my job is actually to make sure that you figure out a balance. And sometimes my balance doesn't look the same. Like, again, they might say, Trish, well, you're doing these things. And I'm like, you don't know what else I'm doing for my own well-being. So I have to make sure that I am assessing and monitoring well-being, right? Monitoring for impairment, ability to discuss difficult cases, that somebody needs that space, that the connection and being able to have a conversation. That again, that's the curriculum that we run within our entire organization, that idea of like recognizing, regulating, and responding. That's a beautiful thing for all of us to do all of the time because we need to build skills. So sometimes people will say, I don't know what to do differently because they don't have the skill. So we don't need to keep telling them to do it differently. That's the same that we do with sometimes with patients. I just want you to be better. I want you to stop doing that. But if they don't know how to recognize when they're about to do it, get themselves regulated to give them the choice to respond, they don't. We're the same. If I don't know how to engage in skills that would allow for me to get closer to my well-being, then how am I going to do it? Right? These are some of the areas. And so a healthy workplace and practice, supportive culture, open communication, decision makings, autonomy, empowerment, employee growth and development. Do you have opportunities for employees to have growth and development? Even if it's outside of their scope, do you have opportunities where they can learn, where they can train, where they can engage with others? Recognition, right? So we saw that one of a critical component of well-being is within the workforce. Think of how much time we spend there. Are we recognizing them, right? Are we compensating them? But are we recognizing them through the work that they're doing? When we look at work-life balance, as I said, it's not about like, oh, it's 5 o'clock, you got to go. if you're working, do you recognize that there's spaces for you to have some level of flexibility? Some of us have to be in the facility. That's just the way that it is. So where do we find the work-life balance? How are we communicating this? How are we accessing some education and recreation that allows for a better balance? How are we attending to our emotional and our physical and health safety? How are we looking at that? How are we addressing it? How do we monitor it within ourselves so that we are able to show up better for our patients? And then regular feedback, performance reviews, constructive feedbacks. Are you comfortable with it? Are you comfortable with talking about it? Have you received it? Because when we can hear what we can do differently, how we can do better, how we can be showing up differently, we tend to respond well because this is a core aspect of our overall well-being. And then I'm going to end in this slide, which is the demonstration of normative appropriate conduct through personal actions and interpersonal relationships, and the promotion of such conduct to followers through two-way communication. The role of ethical leadership, recognizing our own ability in our own ethical leadership through these guidelines. Fairness, right? Increase when we engage in supervisory feedback that is perceived to be fair. These are all of the things that contribute to our overall wellness. So we are right at time. I'm going to go through these questions. If you are done, then you can certainly hop off, and I appreciate your time. This has made me recognize I may need a new supervisor. Oh, can you share questions I could ask while interviewing a new supervisor to get an idea of their style and if they will support not only my clients, but create space for me? I think you just asked it. This is a great way. You just did it. Kudos to you. Take what you just texted inside of our chat and ask that as a question, because that is beautifully put. So I would do that. Do you have any trainings available on vicarious resiliency? I have done that in the past. It certainly could be a PBHU for 2025. So I will keep that in the back of my head to be able to do that. And what is the ethical obligations of our organizations to support the well-being of our direct service employees besides telling them to care for themselves? Can you talk about how workplaces? So hopefully this answers something, right? These are some of the ways that we can do that with staff appreciation, with being able to recognize somebody, shout outs, right? I like doing that. Like, hey, I just saw that you did that with that patient. Kudos to you. Creating a work environment that allows where somebody can say, I'm having a difficult day and it's okay. When I do trauma-informed trainings, I always say, in order to truly be trauma-informed, not only are we that for our patients, but we are really good colleagues. It means that we recognize within each other that somebody could have a bad day and it doesn't define who they are, but that we support each other. So those are ways that you can support the well-being, that it's okay to talk about things that are difficult. It is okay to talk about that you're not okay. It's okay to not be okay, but how do you need to show up differently? Is that the ethical consideration? So with all that said, this is the last slide. So we all need to remind ourselves of why we are in this field and how the work has led to unique and profound, if sometimes elusive, pleasures. We are all doing this because we believe in it. Make sure you are attending to you before you attend to others, and ask yourself, is it an ethical obligation of yours to be able to do that? Or is it just one of those things that you're like, I got to do self-care? Do you? Or is it an ethical obligation? Because if you don't, it impacts your ability to show up for your patients and your staff. So thank you. Thank you. I appreciate your time. I appreciate you being here. We look forward to you continuing to show up for PBHU, and hopefully I will see you all in November when I do my next training, but I will keep in mind the vicarious resiliency. I love that. Callie, anything I missed? Oh, there you go.
No, I will just add that, if you enjoyed today, we hope you'll come back. Trish is presenting again in November, but next month, fourth week of October, we'll have Rhonda and Megan here with us talking about ASOM and more treatment planning information. And just a reminder, you have until next Friday to fill out that eval, which I will send out in a couple of hours. You'll also get an email if you did not meet the time requirement, so you'll know either way today if you have the eval or not. And we'll send out the recording, some slides, and all these resources next week. Thank you all for joining. Have a great weekend. Thanks, Trish.